All right, may I invite everyone to come in and take your seats? We would like to have a timely start. Members of the previous committee are welcome to stay. All right, so it's time. I would like to welcome everyone in person and everyone who's online to our group meeting, Cancer Prevention and Epidemiology Committee meeting today. We have a busy agenda, great updates, and an invited speaker. Just a few housekeeping notes, especially for our members who are online. Please add your comments or questions into the chat. Myself and my co-chair, Dr. Marian Neuhauser, will be following it. However, you may also unmute yourself and ask questions via your microphone, and I'm guessing everybody will hear the questions. So without further ado, I would like to give the microphone to my co-chair, Dr. Marian Neuhauser, who will be introducing our guest speaker today. Thank you.
Good morning, everyone. It's great to see everyone. And I just checked, we have 35 people joining by Zoom. So we have a great attendance today. Thank you to everyone. It's our great pleasure to have Dr. Eric Klein be our speaker today. He's going to be presenting on the promise of multi-cancer early detection. As you know, this is a very active field. There's a lot of interest from the NCI on this topic. In fact, they have an RFA out right now to try to understand these multi-cancer early detection panel tests that are in development and being used by many companies. And Dr. Klein is known to many of us. He's the Emeritus Andrew C. Novick Distinguished Professor and Chair of the Glickman Urologic and Kidney Institute and Lemur College of Medicine at the Cleveland Clinic. He completed his undergraduate training as Johns Hopkins, and from there went to the University of Pittsburgh School of Medicine, did his residency at the Cleveland Clinic, fellowship in urologic oncology at Memorial Sloan Kettering, and then joined the Cleveland Clinic after that and served there until very recently, where he is now a fellow in the Distinguished Careers Institute at Stanford University. He's been very prolific in research throughout his career. He's a member of many professional science societies and scientific advisory boards, including being on the board of scientific counselors of the NCI and a number of other societies. He was president of the Society of Urologic Oncology from 2009 to 2011. So most of his research has been on prostate cancer with a focus on genomics and clinical trials, and has done quite a bit of leadership in this space over his career. So without further ado, I'm going to turn it over to Dr. Klein, who's presenting virtually. So we will invite him now to share his screen and enlighten us on this important topic. Dr. Klein, thank you.
Yeah, thank you and good morning. Can you hear me and see my slides?
Yes, we can.
All right, great. So pleased to give you an overview of this exciting new field. By way of disclosure, I am consultant for GRAIL, and I'm going to be showing you data from 2 of GRAIL's clinical trials that served the commercial development of their MCED test called Gallery. So we're in the midst of a paradigm shift from moving from single to multi-cancer early screening. And the way I like to think about it is that we're moving from screening for individual cancers one at a time to screening individuals for cancer. And the reason we can do this is that cancers shed biologic substrates into the bloodstream that are now detectable using very sensitive methods like next generation sequencing. And I'm going to organize my talk around these 2 questions. Why is this necessary, and how is it possible? We all know that detecting cancer early is important in terms of having the least treatment burden and the highest chance for cure. This is true whether we measure it by clinical stage at presentation, or even in advanced stages looking at tumor burden. And we also know that we have 5 endorsed screening tests that are currently used, although endorsed with various degrees of enthusiasm by the USPSTF, as indicated by the grades in the second column. But we use them because all of them have been shown to reduce mortality. And so what's the problem then? Why is it, since we have these great screening tests, that we need to think about broadening what we do? Well, here's the problem right here. Despite the fact that we screen for these 5 cancers and that screening people for those cancers reduces mortality, we still lose more than 600,000 patients to cancer a year in the United States. And there are a number of reasons for that. 70% of all cancers are not found because these 5 tests only detect 5 cancers. And of course, there are hundreds of cancers that people can get and die from. We know that adherence rates are suboptimal. We know that even individuals who follow recommended screening guidelines are more likely to be diagnosed with a different cancer than those that are targeted by screening. And I don't have data. I do have data, but I don't have time to share that with you today, but it is true. We know that the positive predictive value for single cancer screenings is less than 10%. And we know that the cumulative false positive rate for these 5 approved tests is very high. If you look at PLCO data, after 10 rounds of screening, the cumulative false positive rate for a woman is 40%. And for a man is 50%. So there's real room for improvement. And the whole idea behind multi-cancer early detection comes from this paper that David Ahlquist, an epidemiologist at Mayo Clinic, published a few years ago. And it's important that we spend a few minutes understanding it. And what you see here, focus on panel A first. On the y-axis is the number needed to screen for a particular cancer to detect a single cancer. And on the x-axis is the prevalence. And what he pointed out is that if you take a rare cancer like esophageal or a stomach cancer, the number needed to screen is so high that it's not possible with current technology to design a cost-effective screening paradigm. And although this improves with cancers that are more prevalent in the population, even these numbers are too high. What he proposed was that if you had a test that was a universal cancer screen or a pan-GI cancer screen, you could aggregate the prevalence of all these cancers and drop the number needed to screen substantially into an area where it becomes cost effective to screen for multiple cancers. And that's what MCED is about. The flip side of that is that if you have a universal test and you can aggregate prevalence, that you can increase the positive predictive value of the test substantially while keeping the false positive rate very low. And I'll show you some data that this, in fact, is possible. So this is a key slide, and I'd really like everybody to focus on this for a minute to understand what the advantages and disadvantages, or what the advantages and practical effects of MCED screening are. We'll talk about some of the challenges a little bit later. So multi-cancer early detection, or MCEDs, detect cancers that are not currently screened for, and that will increase the overall cancer detection rate, which is the only way that we're going to make an impact on cancer mortality. As I just showed you, an MCED approach improves the efficiency of screening by having an improved positive predictive value, which reduces the number needed to screen and reduces the false positive rate. And I'll show you that we can shift diagnosis to earlier stages, and that lowers the burden of treatment and improves the cure rate. 2 key points at the bottom of the slide that are poorly understood about MCED. So I want to be sure that everybody digests these. MCED is not about finding a particular cancer type. It should not be compared to tests that screen for individual cancers. That's not the intent. That's not how it's designed. And the background that I just showed you from David Ahlquist is that we need to aggregate the prevalence across all cancers and consider how these function at a population level. So now that we've talked about why this is necessary, this paradigm shift, let's talk about why it's possible. It's been known for many decades that cancer cells, as they die, put all sorts of potential analytes into the bloodstream. And again, it's possible with sensitive technology like next generation sequencing to focus on one or more of these analytes. And the one I'll be talking about is cell-free DNA. With all these different cancer signals in the blood, as you see listed here, The question is, which is the best signal to look at? And the answer is, we don't really know. There have not been a lot of head-to-head studies, except one that I'll tell you about in a moment. And it's possible and even likely that in the future, although the current tests that are on the market are going to be focused on cell-free DNA, a multi-analyte approach that includes some other things may also be necessary to improve sensitivity. So what's the best approach? In the circulating cell-free genome atlas study, CCGA, that I'll talk with you about, this is the only study that I know of where different assays and different analytes were compared. So we compared whole genome sequencing, targeted mutation, and methylation head-to-head. And methylation was the winner with respect to the lowest limit of detection, so the most sensitivity, and in predicting the cancer site of origin. And that's what Grail's Gallery test is based on. So a little bit of science. I don't have time to go into great detail on this, but the idea here is that you can take a source of cell-free DNA, in this instance, blood. You could also do this on tumor biopsies, but that's not the intent of the screening test. It's blood-based, it's sequenced. The methylation sites are sequenced and analyzed, and then a machine learning algorithm is used to distinguish not only the presence or absence of cancer, but in those in whom a cancer signal is present, what organ system it is likely to arise from. So it is possible, without going into detail, looking at methylation patterns, to do both of those things. So the algorithm outputs, again, are two. One is cancer present, a binary yes or no, and second, a predicted cancer origin. And this is what the clinical workflow, you have a patient clinic who's going to be screened, blood sample, you send it off to the lab for sequencing and machine learning classifier, and the output is this. It's a binary output to start with: cancer signal detected or cancer signal not detected. If a cancer signal is detected, then Gallery and some of the other tests on the market soon will predict cancer signal of origin. This is what a test report looks like for a typical patient. In this instance, this patient had a cancer signal detected, and the predicted site of origin was 90% likely to be head and neck and 10% likely to be lung. And the reason for this, that both of these are reported, is that there is a little crosstalk between different cancers, so that it's not always possible to distinguish with absolute certainty where the clinical site of origin is. But the idea here would be that this individual would be referred to a head and neck specialist for an evaluation for the presence of a head and neck cancer. If that evaluation were negative, then the recommendation would be to proceed for an evaluation with lung cancer, most likely with a CT scan. So let me tell you about the clinical studies that support the commercial use of this test. This is the CCGA study, which was a 15,000 participant study that was divided into three parts. CCGA-1 was a discovery and assay development study. CCGA-2 was assay refinement, where the targeted methylation assay that is currently available commercially now was used. And CCGA-3 was a validation of this methylation assay. And so I'm going to show you high-level results from CCGA-3. And what it showed, this was a case control study, that's important. In the individuals who had known cancer, the sensitivity for all cancers of all stages was just a little over 50%. The signal origin prediction accuracy, so the ability to predict in those who had cancer what site it was from, was almost 90%. And the specificity was 99.5%. Meaning that the false positive rate was only 0.5%. So let me pause here and point out that current screening tests, the 5 that we use currently, are optimized for sensitivity to not miss cancers. And because of that, their false positive rate is relatively high, and their specificity is relatively low. On the other hand, MCEDs are specifically designed to have high specificity, to have a very low false positive rate. So unlike current screening tests, we sacrifice some sensitivity in order to get the false positive rate very low. And so when you'll see, combine these together, you get the advantages of both high sensitivity and low false positive rate, or lower false positive rate. And I'll introduce the concept that MCED is meant to be an adjunct to current screening not a replacement for current screening tests. So what cancers does this particular MCED detect? Well, here they're divided. These are all the cancers that are common. It detected more than 50 kind of cancers. And these are divided into cancers detected that currently don't have common screening options and cancers that do have common screening options. So it didn't work very well for prostate or breast cancer, worked pretty well for cervical colorectal cancer. But these are cancers over here that people die from, for which we don't have current screening. And it detected about 64% of all those cancers. And I like to focus on ovarian and pancreatic cancer. In the current paradigm where there's no screening for these, our detection of early stage ovarian and pancreatic cancer is 0%. And this MCED detected 80%, over 80% of ovarian and pancreatic cancers. And it detected 60% of stage 1 and 2 ovarian and pancreatic cancers. And there's nothing else on the horizon that is going to be that good in detecting, for example, these potentially lethal cancers. Looking at it a little differently, if you just focus on these 12 cancers that account for about 2/3 of deaths in the United States, the sensitivity was even higher. Sensitivity for stage 1 was 37%, for stage 2, 70%, for stage 3, getting close to 90%. And so overall, the sensitivity was 68% for these 12 cancers. So that shows you the power of this particular test to detect cancers with a very low false positive rate. The second study that we just presented at ESMO last month is called Pathfinder. This was an intervention study. Individuals with no real risk factors for cancer other than a smoking history or a prior history of a visceral malignancy that was cured more than 3 years earlier, or a genetic predisposition. Otherwise, it was the intended use population, adults over age 50, who got the test, and the results were returned to the participant and to the physician, and we allowed the physicians to do the workup. And so the idea here was to understand how the test performed in the intended use population. And here you see a diagram of all the cancers that this test detected in an asymptomatic, healthy, intended use population. And what I'd like to point out, the highlights are this, that 40% of the cancers that were detected by this test were stage 1 or 2, and more than 70% of the cancers that were detected by this test lacked standard screening, which I think shows you the power of the paradigm. From that data from CCGA and Pathfinder, we have been able to model that if this particular test or tests like it were to perform in the general population the way we saw in the studies, that overall cancer mortality could be reduced by about 1/4, which is very impressive and equally important in terms of causes of death relative to other causes of death there in terms of magnitude. There are some challenges potentially with MCED. One is overdiagnosis. And of course, with screening tests, we worry about overdiagnosis. But there's solid evidence now, not only from the CCGA study, but from another study just published by Foundation Medicine, that cancers that are detected by assays for cell-free DNA that's circulating in the blood tend to be the more aggressive ones. So what you see here, if you just focus on the left side here, in the blue are the cancers that the test missed, and on the red are the cancers that the test detected. And this is Kaplan-Meier survival for those who had cancer. And what you can see here is that these tests preferentially detect cancers that are more aggressive, which are, of course, are the ones that we want to detect. So I'm not saying that overdiagnosis won't be some issue with these sorts of tests, but it's likely to be minimized compared to our current screening tests because of this observation. A second concern is false positives. And as I've mentioned, for example, Gallery has a false positive rate of 0.5%. So yes, the overall false positive rate will go up. But here's a number that no one thinks about. Current screening paradigm, every year in the United States, there are 8 million false positives. Adding 0.5% increase, when you add an MCED, increases that by about 535,000. So the false positive rate, or the total number of false positives will go up. However, when you combine standard screening with MCED screening, screening becomes more efficient and the overall false positive rate falls. And that is exactly what Ahlquist predicted in terms of universal cancer screen. What about cost? It certainly will cost more to screen more people. We think screening the eligible population of about 107 million will cost another $3 billion. So the total cost will go up. However, the return for that is that the number of cancers detected goes up by more than twofold, and the cost per cancer detected falls by more than 12 times. So this is another way of looking at screening efficiency, even though it will cost more to screen. So let me just conclude with a couple of final thoughts. The intended use for these tests initially is, not initially, but always will be as an adjunct to current screening tests, not to replace them. In the short term, this is my opinion now, it's appropriate to think about patients who are at high risk for cancer and use it there. And in the longer term, it's hoped that this will be taken up in the general population in adults over 50. So in summary, despite the fact that we have 5 screening tests that reduce mortality, currently more than 600,000 people a year die of cancer. Adding an MSED has the potential for a 26% reduction in cancer mortality. And I'd like to encourage everybody to get past the status quo bias that we have now, and we stop screening using a spoon and we start screening with a more efficient way of screening. So I will stop there, and I'm happy to entertain questions.
Thank you so much, Dr. Klein. For those of you who are in the audience, you can make your way to the microphones. We're going to start with a question in the chat, and that question is, has MSED test been used in patients with cancer of unknown primary to detect site of origin?
Yeah, not to my knowledge, it has not, but it's a good idea. It might add some value.
Okay, other questions? It looks like we're going to have a question coming to the podium.
Wonderful presentation. Thank you, Nicole Kudra, Kirkland, Seattle. Interesting slide about the cancers that were missed appear to be the less aggressive.
Can you speak up, please? I'm not able to hear you very well.
Thank you. Interesting. The cancers that were missed appear to be the less aggressive cancers. Can you break that further down? Were there any aggressive cancers in that missed population? There probably were some left, I suspect.
Yeah, so we've looked at the cancers that were missed in the Pathfinder study because we have 1 year follow-up, and there were some cancers that were picked up through routine screening. Most of the ones that were missed were thyroid cancer. We didn't catch any of those, and that's fine because thyroid cancer generally is not one that's lethal. And then there were a number of stage 1 lung cancers, and I think there were 1 or 2 stage 2 or 3 cancers of other organs. And what we've learned is that the test depends on having enough signal in the bloodstream to detect. And the cancers that were missed had levels of cell-free DNA in the blood that were below the limit of detection.
Okay, we're going to go to the next question online, and then there'll be one coming from the room. Dr. Manazian says, nice talk, but what is the timing of those cancers that were missed?
Yeah. Hi, Laurie. So some of the cancers were picked up in the 1 year follow-up of Pathfinder. Again, the individuals who went through routine screening. And then we don't have the data yet, but from CCGA3, we have 5 years of follow-up in that study, or will have it, and we'll be able to see what the timing was, who was diagnosed in the first year, who was diagnosed in the second year, that sort of thing. I can tell you that nobody who had a false positive test ended up with cancer within 1 year at the end of the Pathfinder study.
Okay, we'll go to a question here in the room, and you can let Dr. Klein know who you are.
Okay, thank you. Thank you. It's a great talk and exciting. But my name is Hildy Dillon, and I'm the advocate on the Lymphoma Committee. So my question is, aligned with this information and if this becomes available, what type of clinical education will go along with this so that we don't end up in the same situation that we have with mammographies, where a lot of women have suspected diagnosis, a very, very early diagnosis, and have been overtreated. For example, you use lymphoma as an example. There are several lymphomas that you don't necessarily have to treat when you're first diagnosed. So there needs to be some education that goes along with this. And the second part of that is privacy, because I would hate to see insurance companies use this risk, which may actually be years later down the road, that this disease might impact a person. And like if somebody ticks off that they're a smoker, their insurance rates go up, or they lose their insurance, their health insurance. So any thoughts on that?
Yeah, both important questions. I don't know what FDA will be willing to endorse in terms of indications for these sorts of tests. FDA has been engaged with all of the companies that are working in this space to develop a paradigm for evaluating them and coming up with what will be a label indication. And so that's work that remains ahead of us. And the second one is with respect to insurance discrimination. So you raise an interesting point here. There is an act or a law that has been passed called GINA, which is the Genetic Non-Discrimination Act, that prevents employers or anybody else from using genetic information to discriminate. Whether this would fall under the GINA or whether new or additional legislation to protect people would be necessary, I think is something that needs to be discussed.
Okay, and before we go to the next question in the room, there was a comment online that smokers are supposed to describe their conditions, on questionnaires, including for health insurance. So they shouldn't be hiding that in the first place. Okay.
This test will not help them. This test cannot detect who's a smoker and who isn't.
So this is Dawn Hirschman from Columbia. I guess my question is really in terms of how we think about the design to show that screening improves mortality that's not modeling based. Because if the cancers that are being detected are the more aggressive cancers, then you have to assume that early treatment of them is going to change outcome, which we don't know. So I guess my question, and every one of these cancers is potentially different, both molecularly and biologically. So, and anatomically. So what is the best design to show that this kind of testing changes, which cancers this changes outcomes for, knowing that the adjuvant treatments for many of these cancers have not been defined?
Yeah, great point, and subject of a lot of robust discussion in the community. And I just came back from the early detection meeting that's being held in Portland, where we spent a lot of time discussing this yesterday. A mortality trial is, the gold standard. The challenge is that mortality trials and reporting results take a very long time. So if you look at the PLCO trial and you look at the ovarian arm of that, it took 19 years to report negative results. And so, and there are lots of other examples of that. And it took more than 20 years for the prostate arm of PLCO to be invalidated because the drop-in rate, the contamination rate with PSA screening in the control arm was so high. And I think there's a general sense amongst many, not everybody, that this technology is so exciting and potentially game-changing that we can't wait 20 to 25 years, because the technology that's available 10 years from now and the treatments we have available 10 years from now are likely to make whatever we do now irrelevant anyway. So there's a lot of robust discussion about whether or not we could use a stage shift as a shift away from late stage disease to early stage disease as one surrogate, or alternative endpoint is probably a better term. Whether we could use the percentage of individuals who are eligible for curative treatment, whether there's an advantage to detecting even advanced stage cancers when they're asymptomatic, and so forth. But one other thought that I find tantalizing, and you raised a good point, we don't know if the treatments that we have available currently for late stage disease will work in early stage disease, for example. we don't know if surgery, for example, works for stage 1 pancreatic cancer or stage 2 pancreatic cancer. And the reason we don't know is that we don't see stage 1 and stage 2 pancreatic cancers. And so I think there's hope, at least I'm optimistic about this, is that we're going to create a new state of individuals whose cancers are caught earlier, where we can test various treatments and figure out what works for early stage disease to sort of prove the point that you have raised. So it's a great point, and there is not a simple answer to it. It's very complicated.
Okay, we'll have another question from the room, and then we may need to move on after this.
Again, fantastic effort, difficult effort, early stages, but it is the future. And Nicole Kudera, Kirkland, Seattle. Just to follow up, a comment and a question. The stage shift is an interesting thought as an outcome. And I wonder if the imaging world is not an interesting help for you, for your paradigms, as we have not, imaging changes have not shown survival improvement either. And we've allowed more sensitive imaging to emerge in clinical practice. The question I have is there a model for germline families at high risk for developing cancer that might be the prime target here to start off with? And maybe the second part is, do we maybe need basket trials or umbrella trials, once we've identified these novel earlier stage aggressive cancers, and then assess how therapies work? And as you mentioned, we will have to assess various therapies, and SWOG has been really spearheading these paradigms. I wonder if we need the same for what we've done in the genomic medicine era, also for screening.
Yeah, so basket trials are interesting, and they require or designed to target specific driver mutations. And these tests are not, at least this particular test, does not look at driver mutations. It just looks at the presence of methylated fragments of cell-free DNA in the blood to determine the presence or absence of cancer. So it's not intended to help choose therapy. You raise an interesting question about screening individuals at high germline risk. And so I think personally, I think that's going to be a sweet spot for these tests. But let me share some details with you about a recent publication from Hopkins. They have a high-risk pancreatic cancer clinic that's based on family history and germline mutations and so forth. And those individuals are screened every year with endoscopic ultrasound and MRI, and they reported in JCO very recently two important things. One is that screen-detected pancreatic cancers in that cohort had better survival than non-screen detected pancreatic cancers. And to my knowledge, that's the first time that's been shown. More importantly, they showed that even individuals who are being screened because they're high risk for pancreatic cancer were 7 times more likely to be diagnosed with something other than pancreatic cancer. And endoscopic ultrasound and MRI that target the pancreas don't diagnose those cancers. So this sort of test would be a perfect adjunct for that kind of high risk population.
Okay, our patient advocate, Cheryl Jernigan, is going to get the last question. And there's one question in the chat, and Dr. Klein, if you could respond to that in the chat after Cheryl asks her question, then we'll need to move on to our next item. Yeah, go ahead, Cheryl.
Not so much of a question, but bringing this home, if I can. Having just gotten a call last week from a dear friend and colleague in healthcare who was diagnosed with stage 4 pancreatic cancer with no real symptoms. It took him a week in the hospital to determine it was actually pancreatic. And by the time they figured it out, even worked her up for surgery, she had no options. She went into hospice. She called me very upset and angry about having been diagnosed with no history, nothing. And so I applaud you for what you're doing, because it's those people that I think we can help. And I hope that the long-term outcomes are good, both in terms of how long they live and how well they live. But based on Edna, I applaud you for what you're doing.
Well, good. Thank you. I'm sorry for your loss there. And we're all hopeful that this sort of approach can address that particular issue. So the question in the chat is about tissue samples needing to match what's in the bloodstream. So My understanding, first of all, that's a different clinical scenario. Those are patients who already have cancer, and where you're doing the cell-free DNA to help either stage the cancer or determine prognosis or find an actionable mutation that can be targeted with the drug. The correlation between what's in the blood and what's in the tumor tissue is good, but not perfect. But conceptually, an MCED is used in the screening setting in patients who are not known to have cancer, and they're not used for picking therapy or that sort of thing. So it really isn't necessary to get tissue, even though you could do the same assay on the tissue if you wanted to.
Thank you, Dr. Klein. This stimulated a lot of questions and some good discussion. And I think, over the next several years, we will hear more about MCEDs, especially after NCI receives applications from the RFA that they have out, and that research is conducted, and we have more questions and potentially more answers. So thank you very much. We really appreciate it.
Thank you. So long.
All right, so continuing with our agenda, I would like to invite Cheryl Jernigan, our patient advocate, to give us updates.
Good morning. I would like to say that your Patient Advocate Committee has been working diligently on has been working diligently on diversity, equity, and inclusion. This initiative is very important to us, and it's all about representativeness. DEI at SWOG is asking and delving into the question, how representative are we in who we are and how we work and who and what we study? In assessing who we are, we've already come up with recommendations, specifications for membership and leadership and how to improve the representativeness of both of those. And we have new leadership roles that are helping drive this initiative within SWOG. And it is a cultural change. It's a change in the way we think and see things and do things. Most recent addition was our DEII Vice Chair, Don Dyson, and I think it's interesting they've added that second I for integrity, which is what research is all about, in my opinion. And I want to highlight the importance of our community advocates. We have now on board 5 community advocates, and we hope at some point to have 10 communities represented. We're gradually bringing these folks on as we learn how to best deploy their voices and use them within the SWOG's decision-making process. But these people are embedded in their communities. They know what the patients and people in their communities want and need, and they are willing to work with all of us as we work through our trials and issues. We are, as I noted, we're hoping to add 5 more. I will say that we have people on the PAC already who are from these communities. The difference is that these are new, what I call naive, or people who have not been involved in research. So they see things even a little bit differently than the research advocates may. And how representative are we as the community advocate, as the Patient Advocate Committee? Well, when you look at this new resource guide, and this picture on the front of that guide kind of gives you a visual. We've improved our diversity and our representativeness when it comes to ethnicity and race, but we are having some big problems in gender. We have few men, and we need more men. Last I checked, the statistics were there about 50% of them, and we don't have 50% on our committee here. And then we also have a tendency to skew more to older, and many of us are breast cancer survivors and co-survivors. And when we are thinking about how we work together to improve our diversity and representativeness, the SWOG, or excuse me, the Team Science Module 6 really provides some excellent tools, advice, and data resources for us. Training has been completed by the PAC and by the Retention and Recruitment Committee, as well as our leadership and committee chairs. Ours were among the first. So applauds to them. And then our pilot study PIs, excuse me, and champions have all taken this. It has, the rollout to membership has been held pending the actual rollout of our new leadership management system. management. And in case you didn't catch it, this is in your programs for this meeting. And this is now being, the learning management system is now being rolled out in a soft rollout. So I wouldn't expect that our rollout formally to all of our membership on the SWOG module 6 would be too far behind. So, but meantime, for help and assistance on how to include diversity in your thinking as you go through the clinical trial process, we have this infographic that we passed out at the last meeting, and it says at each stage of the clinical trial process, things you can do to improve diversity and representativeness. For instance, in the defined stage, we need to develop preliminary forecast of the subpopulations, discuss subpopulation barriers, and also brainstorm solutions. But you don't have to do this alone. We have the community advocates that can help us on this, as well as the Retention and Recruitment Committee. And if you attended the Digital Engagement Committee, you also know we have that resource for anybody who thinks that maybe social media, videos, or other forms of digital engagement may help your trial in terms of recruitment and in terms of retention. They're an excellent resource to brainstorm with. So ensuring representativeness in a SWOG study, it's everyone's job. We all need to be involved. And we do have our DEI champions who are learning a lot as they go through the pilot studies, and they will continue to share with us the lessons they've learned and the wisdom they have gained. We also have coming on board a draft report of clinical trial results. And this report, the draft report, now shows accrual tables by gender, race, ethnicity, and age, and these will be done for each trial and each SWOG committee. It will be our dashboard about how well we're achieving our goal to become more representative. And as you start designing your trials, the best place to start in reaching those goals is to forecast your goals. And traditionally, this part of the protocol has been developed using SWOG's historical trial results. And as we all know, those don't usually reflect the study population or the general population at all. So moving forward, or I should say now, that is all changing. The team science module is helping us do this. We have other resources I've just mentioned that are helping it. Forecasting is a team effort. And forecasting subpopulations, the things we need to keep in mind is we have to be DEI intentional from the get-go. We have to be aggressive and achievable. And by intentional, I mean, this is a commitment. It's a commitment to assuring that our trials and our results are representative for all the patients and communities that they're intended to serve. So aggressive in reflecting the subpopulations in the entire population study population, I should say, and achievable by acknowledging some of the historical problems we've had with our accruals in the past and identifying challenges and barriers, and also identifying solutions or ways to get around those. It's an iterative process that begins from the very beginning of concept design and runs all the way through when we finally publish and share those results and hopefully implement them. And please note that when we're talking about mirroring the study population, we're talking about representativeness, but representativeness doesn't mean it will be statistically significant. The goal here is to get to basically achieve results that are generalizable to the entire study population, and then hopefully pick up signals from subpopulations where they exist. And representative does, however, mean that it's relevant to the entire study population. And module 6, it's interesting because in reading one of the first examples under forecasting that it gave, it was a situation I ran into on the NCICRB about 3 or 4 months ago. This was a beautiful study, great study. And the background in it was exciting because it could really help Black males. And so then when I looked at accruals, it was a total disconnect. Hardly any males were seen in the accrual goals were going to be recruited into the population or the study that was going, the participants that would be studied. This is a disconnect that we've got to start connecting. And according to what's given to you in Module 6 now, it says if previous studies shows there are significant differences in the proposed intervention's effect based on gender, race, or ethnicity, then your trial must include enough patients to answer the intervention question in each of the impacted subpopulations. So DEI or representativeness is no longer an option. It is an imperative. It always has been. We just haven't realized it. Only with a diverse representative group of people can you be more confident that the results will reflect those and help those who will one day have to use this intervention. By being representative, we'll know more about how well the intervention works, its side effects, and how it affects the various ethnic groups. The last thing is representative. All trials must be representative to be relevant to the populations we're hoping to serve. And I want to thank you for all the things you're already doing to try to do that and encourage you to keep going. And it's something that we're all learning together. So be happy to take any questions if you have any.
Thank you
Thank
so
you.
much, Cheryl. This was very informative, and congratulations, on all of these initiatives you guys are doing. Any questions for Cheryl? Online or in person? All right, I think we can move on.
Okay, our next presenter will be presenting online, and that's Dr. Jason Zell. He'll be presenting on SO820. And Jason, just let me know, just say next slide when you want me to go to the next slide.
Okay, thanks. Let me know if you can't hear me very well.
Yes, we can.
Okay, great. So this is the update for S0820, so-called PACES, the phase 3 trial of eflornithine Solndac in patients with colon or rectal cancer. We've had a great study team over the years. I'm only listing a few of the people involved on this cover page, but obviously many of you in the room and online have helped support this trial. All right, next slide. I really just have one slide today. It's just the update with the accrual and the schema. So in the redesign, we have a two-arm trial, combination of eflornithine Solndac versus combination placebos for resected colon or rectal cancer patients, stage 0, 1, 2, or 3. This intervention commences when patients are approximately 1 year post-op. So it's a true prevention trial with the prevention endpoint being a 60% reduction in high-risk adenomas or second colorectal primary cancers between the post-op year 1 colonoscopy and the post-op year 4 colonoscopy, which is standard. So here's where we are. In the redesign, we need 389 patients, and we have 342. So I believe this month we've accrued 2 patients. In October, our goal per month is 3, but it would be nice to do better than that. Some months we do, some months we don't. So we still need everybody's effort. Lately, we've been accruing pretty well at Irvine. We have about 10% of the accruals nationally, over 30 patients we've accrued to this trial. And we have a couple that are actively in the late stages of screening, should be registered very soon. So for those of you who have figured it out, keep at it. For those of you who need help, we've got a very responsive team, so let us know. Monica Yee and I usually field those questions right away. And if we need help, we go to our statisticians, Joe Unger, Katie Arnold, and the rest. So with that, I'm going to leave it there for any questions. That's just the update. We are getting much closer, but we still need help to close this out. So I'd be happy to take any questions you have about the protocol.
Great, thank you, Jason. You're getting so close to the finish line, which is great. Are there any questions online? Sure, go ahead. Tanya, go ahead.
Okay. So one question online is, what is the frequency of ototoxicity in the study to date?
Well, we don't know that yet. I mean, that's going to be one of the secondary outcomes, which there's no data on that yet. I will say how about this? For publicly available data, which you can all look at on the published report of SWOG, there doesn't seem to be any greater number of discernible adverse events in the placebo arms versus the eflornithine Sondac. Ototoxicity would not be one of them, but hearing loss, clinical hearing loss would be. So I don't know which arm's which, but I know that without any statistical analysis, the proportion seems to be about the same, which is very consistent with what we saw in the prior phase 3 trial of Frank Maskins in adenoma patients. There was no difference in hearing loss. The difference in ototoxicity was 7%, non-significant in the prior trial, which had 267 patients. And that was transient at the end of study, when they removed the drugs, 3 months later, the difference was about 1%. So the difference is small. We're much more restrictive about what it takes to get on this study. More restrictive than the prior adenoma trial. So I'm hoping in the end that leads to a safer, even safer signal with regards to ototoxicity.
Thank you. And before we go any further, there was a comment online that those online cannot see the slides. They can only see who's talking.
Yeah,
So,
I had to pin mine too. So because I couldn't see my own slide, it was too small. So yeah, just go ahead and pin it and you'll be.
yeah, so I think we need to have that remedied before we go to the next presentation. Any questions in the room for Jason? Okay, let me try to go to the.
Okay, wonderful. All right, so I would like to introduce our next speaker, Dr. Nappi, who will be joining us virtually online as well. She will give us an update on S1823 prospective observational cohort study to assess miRNA 371 for outcome prediction in patients with newly diagnosed germ cell tumors. And I will be forwarding the slides for you.
Okay. Thank you
Can
very
everyone
much.
see the slides now online?
I can see mine.
Okay.
Okay, that's a good sign.
Can you hear me okay?
Yes.
Okay. So if you can go back to the previous slides, please. Okay, so I'm going to give you some updates about this study S1823, which I co-chair with Dr. Nichols. So just a little bit of background. I know that most of the Prevention Committee knows about this study and about the background, but just for the people who are not familiar with this project. So we are evaluating a microRNA, which is a very small RNA that is particularly specific for germ cell tumor. So we know that we can find it in more than 90% of our patients with testicular germ cell tumor. And the most important thing is that both seminoma and non-seminoma germ cell tumor are able to express a high level of this microRNA 371. It's very specific for non-seminoma and seminoma germ cell tumors, since the only other condition where we can actually detect this microRNA is pregnancy. It is not expressed by a subtype of non-seminoma, which is a teratoma, particularly well-differentiated germ cell tumor. And the beauty of this microRNA that makes him particularly suitable for a biomarker is that it's extremely abundant in the blood. So it's secreted in the bloodstream, and we need a very small amount of blood to detect this microRNA. Rapidly decrease and disappear after successful treatment. And I just included the heat map here from the initial discovery of this microRNA, just to give you an idea of how discriminating this microRNA expression is between tumor and non-tumor cells. Next, please. So as mentioned, this microRNA is very abundant in the bloodstream. It's related to tumor burden. So the more advanced is the cancer, the higher is the expression. It's very stable, unlike circulating tumor DNA or RNA. MicroRNAs are very stable in the peripheral blood. We need like a very small amount of blood to detect this microRNA. Next, please. Just 50 to 400 microliters of serum or plasma. We currently use 200 microliters in my lab. Next.
we use a relatively easy method to quantify the expression, which is a real-time PCR. Next, please. And the extraction kit and reagents are commercially available. Next one. The cost is limited, it's about $60 per sample. Next one. This is like the half-life of this microRNA 371, which is a very important characteristic for this microRNA, because we know that it clears relatively quickly after surgery. So the half-life is about 18 hours. Next, please. Most of the patients do not have detectable microRNA 371 post-orchiectomy. Next. This is an advantage compared to what we currently use, which are alpha-fetoprotein and beta-HCG in testicular cancer, which have a much longer half-life. So sometimes we have to wait long periods of times to make sure that actually there is no tumor, just according to the very long half-life of these tumor markers. Next slide. Next. So our work on microRNA was published in JCO in 2019. This was a pilot study done in British Columbia, where we were able to essentially define very high accuracy for microRNA 371 with an AUC of 0.97, much higher than CT scan and tumor markers with high sensitivity and specificity. And based on this pilot study, we decided to design S1823 because we need clinical utility validation on a larger cohort of patients to essentially answer to the question whether or not we can use this microRNA for to predict clinical relapse in patients with early stage disease. So the design of S1823 is very easy. Patients with any stage of germ cell tumor. Sorry, can you go back?
It's on automatic. I'm not actually doing anything. It's going fast. But tell me if you want me to go back, please.
Yeah, that's fine for now. Essentially, patients at any stage of germ cell tumor, either gonadal or extragonadal, are eligible for this study. And they are required to provide extra blood for microRNA extraction at the time of enrollment to the study and during their follow-up. And at the time of relapse, if the patients will have a relapse. The blood are collected in Streck tubes and are sent to nationwide for quality control. And then I receive batches of aliquots for the microRNA 271 analysis. And this data will be circulated back to SWOG for correlation with clinical data. So one thing to point out is that we don't use any real-time microRNA results to inform a clinical decision. So this is a purely biomarker validating clinical trial. Next one. The patients are divided in 3 groups, low, moderate, and high risk based on their theoretical risk of relapse. And the schedule for the blood collection really depends on this risk allocation. Next, please. So for the low and moderate risk, we have currently blood sample taken every 6 months and 3 months respectively. And next one. For the high risk is more severe, and it's essentially prior to definitive treatment, post-definitive treatment. It could be chemotherapy or surgery, and post-surgery if patients also need surgery after chemo. Next. We currently have completed the accrual for the high-risk cohort. So we have 143 patients in the high risks. We are not actually enrolling any new patients with metastatic disease, but we are still enrolling patients with the low and moderate risk, so patients with stage 1 or stage 2 germ cell tumor. The primary endpoint of S1823 is essentially to establish the positive predictive value of microRNA 371 in predicting active germ cell malignancy in early stage disease. And in the stage 1, to establish whether or not microRNA is able to precede the clinical identification of tumor relapse. This is the statistical design. So we target 50 relapse in early stage seminoma and 100 non-seminoma, and we plan to enroll 956 patients. The follow-up for patients who do not relapse is up to 2 years, because we have very few relapse after 2 years. And the interim analysis planned at 4-day relapses. Next, please. So the study was open in the US in June 2020, and the first patient in the United States was enrolled in July 2020. The first Canadian patient was enrolled in December 2020. So this is a SWOG and CCTG joint effort. And the accrual has been fantastic so far. So we are more than half accrued. As last week, we had 593 patients enrolled in this trial. And as I mentioned, the high-risk group is currently closed for accrual, and those are the numbers for low risk and moderate risk. So thanks everyone for enrolling patients in this study. Next one. We are working on a revision of the protocol to make eligibility easier and to ease up the enrollment of patients and sites. One of the modifications is the time from diagnosis to enrollment that is currently 42 days. We, in the new version of the protocol, we're allowing up to 60 days because we had a lot of input from the sites about the tightness of this time frame. And we're also facilitating the enrollment by reducing the eligibility in terms of tumor markers, and this will further ease up the enrollment, we think. Next, please. So in terms of funds, we received NR1 that was then transformed in NR37 by NIH, and this is going to cover the analytics cost for microRNA 371 for this trial. And I also received a DoD Career Development Award that is correlated partially to S1823 and will essentially support my lab to also develop even more sensitive kind of methodology for these microRNA or for other markers for testicular cancer patients. Next one. And I think that's my last slide. Thank you.
Wonderful. Thank you so much for the presentation, and congratulations on the accrual and the grant funding. We have one comment virtually that actually, as of this morning, 601 patients have been enrolled. Now I'm opening the floor to questions, either here or virtually, for Dr. Nappi. Looks like we don't have any. In that case, thank you very much again for attending and presenting.
Okay, we're going to move on to our next presentation, which is Dr. Kathy Crew, who will be presenting here in person on S1904.
So good afternoon, and I just wanted to give you a brief update on this ongoing trial where our main objective is to address the low uptake of chemo prevention with SERMs and aromatase inhibitors in women who are at high risk for breast cancer. So this is the overall schema. This is a cluster randomized controlled trial because we have a multi-level intervention that's targeting both patients, the high-risk women, and also their healthcare providers. So 26 sites, we call them recruitment centers, are being randomized 1-to-1 to the active intervention, which includes standard educational materials, plus our real risk and BNAV intervention versus standard educational materials alone. And just to briefly go over the intervention, these are both web-based decision support tools. So they're not just educational tools. They're meant to help women make decisions about whether chemoprevention is right for them. So we actually return to them their personalized risk scores, and there are also interactive modules that will help them elicit their preference solicitations about whether they want to start these medications or not. And then based upon their interactions with real risk, their healthcare provider gets a summary of their risk profiles and the risks and benefits of the different chemoprevention drugs, and also their intention about whether they are likely to want to start chemoprevention or not. So our target is to enroll 415 women. We're specifically targeting high-risk women with atypical hyperplasia and lobular carcinoma in situ because this is the patient population that's at particularly high risk for breast cancer. Their 10-year risk is up to 10 to 20%, and they derive the greatest benefit from anti-estrogen therapy, up to a 60 to 70% relative risk reduction. We're also enrolling their healthcare providers because we have this BNAV tool for the providers. And our primary endpoint, because this is a preference-sensitive decision, is to actually look at chemoprevention informed choice in the patients at the 6-month time point. But secondarily, we'll also look at other patient-reported outcomes. We'll look at actual chemoprevention usage and adherence. So the patients will be followed every 6 months for the first year, and then yearly thereafter to look at actual uptake, actual breast cancer incidence, and early discontinuation of the medications. So this is funded by a 5-year R01. So aim 1 is to actually conduct the clinical trial to look at the effectiveness of these tools. And aim 2 is actually an implementation aim where we're going to interview a subset of the patients and providers who are in the intervention arm to see how well the tools are working in terms of integrating into workflow and how useful they are to them. So I wanted to just discuss a couple of what I would consider successes and challenges with this study. So some of the successes, we have enrolled all 26 recruitment centers. 2 of them in the control arm have subsequently dropped out, but we were able to find 2 replacement sites relatively quickly. So I think the message in terms of these sort of cluster randomized controlled trials is like you have to keep the sites engaged. So we have like monthly meetings with clinical research coordinators at each of the sites to sort of get feedback from them directly. We've had good provider accrual at each of these sites, so we're close to 80% of the way through with enrolling the 200 providers. We've completed over 80% of the baseline interviews with the providers at the intervention sites, and we're more than halfway through with patient enrollment. So 20 of the 26 sites have enrolled at least 1 patient, so we just passed our 50% point. So in terms of our overall accrual, our target goal for patient accrual is anywhere between 13 to 15 patients, and we've more or less been, with some dips over the summer, have reached that accrual goal. And if we maintain that accrual goal, then we should be able to complete accrual within the next year and a half. And I think I highlighted this in our last group meeting, is that we have over 40% accrual from underrepresented racial ethnic groups, including 20% Hispanic, 7% Black, 10% Asian. So I think that part of that is at least 4 out of the 26 sites are MU NCORE sites, and they're among the highest accruing sites. And our tool is available in English and Spanish, and we first tested it in our patient population in New York City. And so we really tried to make sure it was accessible to a diverse patient population. So some of the challenges. So you heard a little bit during the CCD committee meeting, like with these cluster randomized trials, the power is based upon the assumption that we can get equal accrual across all of the sites. And that's challenging to do because each site has different patient volumes, different resources for enrolling patients to this study. So, to get to 415, we'd need an average of about 16 patients per site times 26 sites. And so we know it's not feasible to get actual equal accrual. So we've set certain parameters where we want the sites to accrue an average of 16, but we want a minimum of 8 patients per site, and then we do cap the maximum number of patients per site at 32. So currently, right now, only Miami is close to that cap, and we're doing everything that we can for the sites that are below that 8-patient minimum to keep them engaged and see within the next year and a half, because we hope to finish accrual by then to keep them engaged. I think the other challenging thing is that this is an unblinded study, and the sites that are in the control arm, including our own site, Columbia, is not getting the active intervention. The providers aren't getting any education, and the control patients are just getting standard educational materials that are built into the real risk tool. So I think that one of the things that we've incorporated is that at the end of the trial, all of those control participants will get access to both tools. But I think, from an engagement perspective, we do have more sites in the control arm that haven't enrolled any patients. So we really are cognizant of that and trying to keep a close eye. So the other challenge that we have is with these web-based interventions, this is super easy, you're not taking a drug, it can be delivered online, and we're not collecting blood or additional biospecimens or biopsies. But sometimes when you have this low-touch intervention in an otherwise healthy population without cancer, it's hard to keep the patients engaged and wanting them to actually complete the study intervention. I think most of the data suggests from other web-based interventions, you can get about 60% in terms of those actually completing the intervention. So currently, we have about 75% of our intervention participants have at least logged on or partially completed real risk, and a little under 50% have completed the required modules. And so I think these are ongoing discussions that we're having in our monthly meetings, and we do have some plans in terms of how to increase the completion rate for our real risk tool. For the original study that we did at Columbia, it was more like 3/4 of the patients who've actually completed the tool. So it's a question of testing the efficacy of the tool versus the effectiveness in terms of how does it perform when it's sort of out in the wild. So in terms of our future plans and milestones, we did submit an abstract to the San Antonio Breast Cancer Symposium for their ongoing trials poster session. So that will take place in early December. Now that we have all 26 sites finalized, we're going to circulate a draft of the protocol paper, because I think there's very unique aspects of this cluster randomized design in the cancer prevention setting. Once we complete all our baseline interviews with the providers, we'll probably think about analyzing that data and generating a manuscript more on trying to figure out what the needs are in terms of addressing chemoprevention uptake at baseline from these sites. And then we're about to start this fall the patient and provider mid-implementation interview. So this is after they've actually gone through the tools. I forgot to mention, for the providers, we're getting close to 90% usage of the BNAV tool. So that's pretty good on the provider side, at least in the intervention arm, to keep them engaged. And as I mentioned, we hope to finish accrual within the next year and a half. So hopefully by the end of 2023. We're actually in year 4 of the R01, so that's the other challenge. When you get R01 funding, it's great, but the timing of the trial doesn't always coincide with the grant period. But hopefully, I think that if we can complete accrual by the end of next year, we we'll have enough funds to do a no-cost extension, and then still get the 6-month follow-up data, which is our primary endpoint within the actual grant period. Then I want to also mention, so the other thing with our real risk tool is that's novel is that we're also trying to connect it with the patient's patient portal. So at least for the intervention sites that have Epic as their EHR, they have the option to download data from their medical record to help with breast cancer risk assessment, to get information such as their breast density and their breast biopsy results. And so some of that work we've done preliminarily in this trial, and then Rita Kukafka, who's the other study chair, recently got R21 funding to expand upon that EHR work. And then we also submitted 2 administrative supplements this past fall to do some other ancillary studies, breast imaging studies, one looking at trying to also incorporate cardiovascular disease risk assessment, as well as breast cancer risk in this patient population. So, any questions?
Yeah, thank you, Dr. Crew. That was a great update. You've met a lot of milestones. I have a question about the interviews that you're planning to do. Is that using a set interview guide, or is there any thought about having open-ended, more focus group type discussion? And I'm asking that especially since you've had you've been very intentional about trying to recruit a diverse population into this study, and where each patient is in terms of their own, perceived risk may differ, across various groups, as well as any efforts that they may want to do in terms of the informed choice.
Right, so currently for our interviews, we're planning to recruit 30 providers and 30 patients for the, our goal is 30 providers for the baseline interviews and 30 patients and providers for the mid-implementation interviews. We'd like to get representation across all, we actually have 14 sites that were randomized to the active intervention arm. We definitely want to get, sort of a diversity in terms of breast cancer risk, demographic characteristics. Same for the providers too. We don't want just all medical oncologists. We're also targeting surgeons, gynecologists, other allied health professionals to get a more broad perspective. And we do have an interview guide. It's based upon this CFR implementation research guide. And so, but there are also open-ended questions as well.
Thank you. Any other questions for Dr. Crew? Okay, and there's no questions online, so thank you so much.
Okay, so we now will move to the next section in our agenda, where we will give updates of other group studies with SWOG study champions. The first one is the CTSU Alliance study, establishment of a national biorepository to advance studies of immune-related adverse events. Gary Lehman is the champion. I don't know if he's online or here. Maybe not, then we can move on to the next one.
Okay, so the next one will be presented by Dr. McGinnis, and she is here in person. And this will be interesting to hear about following Dr. Klein's presentation, because it's a blinded reference set for multi-cancer early detection blood tests.
Oh, it's up here.
Yeah, just press the green arrow.
Perfect. Okay, so very timely to discuss this now after our keynote speaker today. So I am the SWOG study champion for the Alliance trial that was just activated in the past couple of months. It's a blinded reference set for multi-cancer early detection blood tests. The study chair in Alliance is Marie Wood. So we already had excellent background on MCED. And so I won't belabor this too much, but basically the purpose of this trial is to take it basically to the level of the NCI and get to create a reference set of blood samples to actually validate a lot of the platforms that are available and being evaluated independent of the NCI. This was actually a sort of a mission that the NCI brought to Alliance specifically to design this trial. So the primary objective is actually not in this specific study to evaluate the sensitivity, but to actually create this blinded reference set of cancer versus non-cancer blood samples that then can be used to validate blood-based assays for inclusion in future prospective trials that I think we were all discussing even what those would look like, focused on defining the utility of these early detection assays. The secondary objectives within this are within cancer patients to evaluate the test performance at the time of cancer diagnosis by tumor type, and then evaluate test performance at the time of cancer diagnosis by clinical stage. And so there are basically three patient populations that they'll be studying. One is patients with newly diagnosed cancer. One is patients with a high suspicion of cancer, which I'll explain in a second. And then they're looking at a healthy control population who do not have a current diagnosis of cancer. So their goal is to accrue 2,000 patients, 1,000 patients with cancer and 1,000 healthy control participants. Cases and controls will be matched by sex and age decade. And then participants will be followed for cancer status 12 months after registration. The schema is pretty simple. So basically, once they've determined to be eligible, they have a one-time collection of biospecimens and questionnaire data. That's basically a health questionnaire. And then they're registered, and then there's an optional collection of blood at 12 months. So the goal is to get that initial blood specimen and then see if we can also get the second collection at 12 months. So in terms of eligibility based upon each group, so in the group with of patients with known cancer, they have to have a histologically confirmed diagnosis with a specific tumor site, which I'll show you on the next slide. No prior treatment, age between 40 and 75, no history of prior in situ or invasive cancer except in non-melanoma skin cancer, no prior organ transplant, and the questionnaires are in English and Spanish, so they have to understand either of those. And here are the eligible tumor sites. It's pretty broad in terms of solid tumors, but also liquid tumors. So it should be fairly inclusive of actually looking at the tumor types that we discussed earlier. So heavy representation from GI, but also, the thyroid, breast, the sort of less aggressive ones we were discussing earlier. Then this is a little confusing with the title, but it'll make more sense when I explain it. So the second group is those patients with this high suspicion of cancer, and it's really those patients whose cancer, they have to go to surgery first to formally diagnose this because of the issues with biopsy accessibility. So those are the patients who have, based upon scans and clinical suspicion, are likely have ovarian, pancreatic, kidney, or melanoma. And they have to have planned surgical resection within 28 days of the study, and then documentation of this high suspicion of risk for central review. Same age cutoffs between 40 and 75, and same issue, no prior cancers, including in situ except for non-melanoma skin cancer, same things we discussed before. And then this is the healthy control population, same age range, again, no prior history of cancer, and they'll also be matching by age and sex to those with cancer. So as I mentioned before, the study schedule is pretty simple. So you get the baseline after consent, and within 28 days prior to registration, you get the mandatory blood samples, which I'll talk about in a section. There is an optional tissue sample collection, which is either a block, or if your study site does not send blocks, a representative slide. And then a mandatory demographic and health questionnaire. And then 12 months, plus minus 60 days after registration, they do follow up with a mandatory cancer status to follow up what the diagnosis was. And then optional blood samples if patients are willing to give at that time. In terms of the actual specimens, so for the blood specimens, there are basically at the baseline and then at 12 months, it's whole blood in Streck tubes, 6 10 milliliter vials, so a little bit larger of a blood collection to allow for future analysis. As I mentioned, for those who consent to biobanking, you can send in a paraffin block or a representative slide that's freshly cut if your site does not send blocks. So any questions based upon that? One thing that I will say is I think sort of thinking about this trial, they sort of match healthy controls and cancer. And I think we won't have any trouble sort of finding the cancer patients in some ways, but how do we recruit the healthy controls is the issue I see with this. One thing that they brought up at the training session was, do you sort of recruit your study coordinators and your healthy team who are at the site anyway, if they're within those age ranges? But I sort of see this as actually being an issue.
Yeah, good question. Are there questions for Dr. McGinnis? I know in one of the slides, you said that the cases had to enroll before treatment, of course.
Yes.
And then, but sometimes all of these moving parts can take a while. So what's the expected, accrual rate, or people all of a sudden not being eligible to donate the blood specimens if they have initiated treatment?
Yeah, in terms of actually accrual so far, so at the sites that have been activated, I forget the number of sites. At last update, they've already accrued over 300 patients. So I think the accrual rate is not so much of an issue. I think they're really looking for those patients who are newly diagnosed even before they go to surgery or get any treatment. So you'd sort of have to hit that sweet spot.
Yeah, it has to happen very quickly.
It's I think sites like ours at Columbia, we have a lot of experience in collecting a lot of these basically databases of tissue samples and blood samples, but I could see it being more challenging for sites that are not used to this. Okay.
Okay, if there's no more questions, thank you, Dr. McGinnis.
All right, the next one I will give a quick update without the slide because it's very simple. It's the ECOG-ECRIN study about TMIST. It's a prospective study in asymptomatic women who undergo screening mammograms. The plan is to enroll 129,000 women randomized to digital mammography or tomosynthesis. And as of October 2022, the investigators, Etta Pisano is the PI, enrolled 75,000 women. So I've been told that enrollment was slow, but it's going well and they will continue. There are no preliminary results or any issues reported for me to report to you. Any questions related to this study? Any online questions?
No, there's no questions online.
All right, thank you.
Okay, the next presentation will also be done virtually by Dr. Hill, and she'll be presenting on the National Myelodysplastic Syndrome Natural History Study. So just say next slide when you want me to advance to the next slide.
Hi, thank you for the opportunity to provide an update regarding the National Myelodysplastic Syndrome Study. Next slide. A brief overview of the study objectives. The goal of the MDS study is to serve as a resource for further investigation of MDS. And towards that end, the study is recruiting participants with myelodysplastic syndromes and collecting serial blood samples and creating a biorepository with link to clinical data. The overall goal is to facilitate biomarker and other risk factor investigations that will be of high impact for MDS patients. So enrolled participants donate biological specimens, including bone marrow and blood samples. They provide details on their medical history. And after pathology review, they are assigned to one of 3 groups, which are being followed up for outcomes. So I have 2 updates regarding this study. Next slide. The first is that as of over just a little bit more than a week ago, the study has been approved to continue recruitment and to expand their recruitment target from 1,750 to 2,000 suspected MDS participants. The study was planned to have completed enrollment at the end of this year. And so the additional recruitment will extend the study for another year. Next slide. More about recruitment. The study is on track to, thus far, to have recruited 96% of those that were planned to be enrolled. And you can see here that includes over 900 individuals in the longitudinal cohort and 750, a little bit more, in the cross-sectional studies. And so the new recruitment will allow some additional individuals to be included. Next slide. Including the fact that within the longitudinal cohort, there are some disease subgroups that have lower numbers. And so investigators who are interested in subgroups will have additional sample size and statistical power. Next slide. I'm often asked about which sites are enrolling in recruiting. And this slide depicts recruitment by state across the United States. It is true that all NCI clinical trial network sites and SWOG and others and NCOR are all eligible to recruit for this study. And so if you have patients that are eligible, please consider enrolling at your institution. Okay, next slide. So the second update I want to report on is progress towards external release of data. The study team was anticipating that enrollment would end soon, and as part of their goal to allow the study to serve as a resource for investigation of MDS, they have developed a web portal that allows investigators to explore the data and to present applications for potential approval for use of the data. Next slide. So the web portal address is given here at the top of the slide. Individuals who go to the web portal can find information in quite detail about the cytogenetics that have been completed, the bone marrow assessments that have been done. They can also examine which participants have digital H&E slides, which there are over 1,100 at this point. They can also look at information regarding participants who have targeted sequencing results, and some of that data, as well as whole genome sequencing, have been uploaded already to dbGaP. Next slide. So the study portal allows investigators to understand the flow of material and information that would be needed to be approved to actually use the data. It includes an interactive inventory browser and a site on the portal allows investigators to submit a research feasibility form. Next slide. So this is a depiction of the inventory browser. It provides information regarding the number of subjects in particular diagnostic categories, which have particular outcomes, and also contains information about the biospecimens available. Next slide. This is a depiction of the resource feasibility form. Investigators can develop an idea or proposal and submit it to the data coordinating committee for starting the process for approval to access the study data and biospecimens. Next slide. In conclusion, I really want to say that MDS study has been steadily amassing a critical set of resources, both data and biospecimens, to really fuel the next generation of studies regarding MDS. And these resources will soon become available to the scientific community. We are very grateful to NHLBI and NCI for support, as well as to those listed here who have served on the steering and advisory committees, and particularly want to thank the investigators who have recruited and patients who have participated in this study. Thanks, and I will take any questions.
Thank you, Dr. Hill. It's great to have such good enrollment to this study and the opportunity to increase the sample size a little bit more to ask some of those additional questions you've mentioned. Are there any questions for Dr. Hill? Okay, thank you.
Thank you very much. So moving on now to S2304, I would like to invite our speaker who is here in person, Dr. Connolly, to give us an update on her phase 2 randomized trial of intraoperative radiotherapy versus no IRT for postmenopausal women with low risk ductal carcinoma in situ.
The green one? Okay, so first of all, thank you for inviting me to give an update. The biggest one is that we actually got a new number. So it's been approved by triage and we're moving forward. So this is the study you've all heard ad nauseum. The primary outcome that we're interested in is to look at ipsilateral breast cancer recurrence among these women who receive IORT with low risk DCIS, who receive IORT compared to those who get breast conserving surgery alone, to look at if it improves outcome. And so briefly, the design is that we're in inclusion criteria for postmenopausal women with very low risk DCIS. These are screen detected, non-palpable unifocal lesions on imaging, which are less than 2.5 centimeters in size, grade 1, 2, and ER positive. So these would be eligible for the trial and would get randomized to surgery, lumpectomy alone or lumpectomy with IORT. Post-operatively, they would get reassessed based on the risk category on post-op pathology, meaning there are certain factors which would cause some of these women to become higher risk than initially they were thought to be. These would be if it's larger than we expected, if it were grade 3, or we had positive margins requiring re-resection. So those women would be off, they would remain on study but would not contribute to the primary aim. And we expect this to be about 10% of the cases based on prior experience. The remaining women would be contributing to the primary outcome. They would be low risk based on post-op pathology, and we'd be looking at them for a primary outcome of in-breast tumor recurrence at 10 years. Secondary outcomes that we're interested in include patient, both toxicity, both physician and patient-reported outcomes, as well as we're interested in cosmetic outcome both by photographic assessment, and we're going to be incorporating a biomarker, the Decision RT tool, which is a tool developed to assess the need for radiation. So these are our secondary aims, and then our other objectives is to incorporate mammography and look at how well Dr. McGinnis's tool, this CIN assessment of mammographic density, correlates to our outcomes. So where we are right now, we were triage approved in September. Then we reviewed the concept with the patient-reported outcome core committee, and they gave us their assessment and some modifications that they recommended to simplify the PROs that we were proposing to use, which is quite helpful. We've done the financial and feasibility assessment. We did get commitment from Prelude, which is the company that has developed the Decision RT tool, that they are going to sponsor that part of the study, and they're committed to this, which is fantastic. And then we've also reached out to Latin American sites because there's a number of sites that have intraoperative radiation outside of the United States, and actually there was a pretty enthusiastic reception of this, particularly Brazil and Colombia stated that they actually have multiple sites with IORT and could potentially enroll. So that was good as well. And so we've submitted the concept now in October, and hopefully we'll be able to present it soon. So that's kind of where we're at.
All right, thank you so much for the update. Any questions for Eileen? I don't see any online. None here either, so thank you very much.
Thank you.
So the next presentation will be an update on S1418 from Dr. Arun.
Yeah, so I don't have any slides because the update is very brief. As you know, S1418 is a breast committee study that is randomizing triple-negative breast cancer patients after standard therapy to pembrolizumab for a year versus placebo. This particular analysis addendum is to look at mammographic density changes induced by pembrolizumab versus placebo. Currently, we are a little on a hold because the study actually completed accrual, so prospective consenting most probably will not happen. Discussions are ongoing to see whether we can do this as a retrospective study with consent waiver. Any questions?
Yeah, any questions for Dr. Arun? It's basically just in a holding pattern now, so. Okay.
All right, thank you.
Thank you.
All right, and I would like to introduce our next speaker, Dr. McGuinness, again, to talk about the amendment to S1007, effects of chemoprevention adjuvant endocrine therapy on a convolutional neural network-based breast cancer risk model using mammographic data sets from 2 studies.
Yeah, so no huge updates from our last meeting, but just to remind everyone of the work we're doing, I'll give a little bit of the background and sort of talk about our next steps. So just a reminder in case people have not heard me talk about this before. So at Columbia, we have a collaboration with Richard Ha, who's one of our breast radiology attendings, who's developed a convolutional neural network-based model that's applied to digital mammograms. This is basically a deep learning technology that reads mammograms beyond what we can see with visualization with radiologists, and also beyond quantification of mammographic density. And the output of this is a breast cancer risk score from 0 to 1, 1 being highest. In a training and testing set, we've demonstrated that it's an accurate, independent predictor of breast cancer risk, and it's independent of mammographic density. We've also been doing some work in the screening population, but specifically in what we'll be focusing on today. We also have preliminary retrospective data that dynamic changes are observed in this CNN risk score with anti-estrogen chemo prevention in high-risk populations. And so representative images on the right are for a patient who had DCIS and received tamoxifen. The baseline is on the left, followed by on the right. And this is basically a heat map that represents ultimately what we get in a risk score, showing the decrease after 3 to 5 years of therapy in the risk score with tamoxifen. In the breast cancer population, we've also demonstrated that short-term change with endocrine therapy also predicts breast cancer relapse. So this is from a retrospective cohort study at Columbia with a little over 800 patients who had stage 1 to 3 hormone receptor positive breast cancer and received adjuvant endocrine therapy. And what you're seeing here is risk scores and changes over time stratified by relapse status. So those who had relapse are shown in the red on the top, and blue on the bottom is no relapse. And what we really noticed, which is also consistent with a lot of literature with mammographic density changes with tamoxifen, is that short-term change from baseline to about 1.5 years actually is what really was associated with breast cancer relapse. And so this has been serving as the preliminary data for a couple of studies sub-studies that we've been conducting using SWOG data. The first in the chemoprevention study setting was from SOH12, vitamin D for chemoprevention. I discussed this more at our meeting in the spring, but I'll review the results again very briefly. And then the second in progress study is really looking in the early stage breast cancer setting with the responder data S1007. So just a reminder of what I presented in the spring. So SOH12 was a randomized trial of vitamin D in premenopausal high-risk women. And the primary endpoint was change in volumetric mammographic density. There actually was no significant difference between placebo and vitamin D with the mammographic density, but we examined the mammographic data sets with the CNN model to see if maybe we would observe something with the model that we could not observe with changes in mammographic density. And actually our findings were pretty concordant with the lack of observed change in mammographic density. We really saw no significant difference in change in CNN score, and including baseline CNN score, change from baseline to 12 months and then 24 months with vitamin D. So actually pretty concordant with the primary outcome of the study. So this is our next step in the breast cancer population. So we aim with responder data sets to then apply the CNN model to really further evaluate and potentially justify prospective evaluation of the model to predict breast cancer relapse. And so in a case cohort study of 845 women within responder, we'll be applying the mammograms, the CNN model to mammograms at baseline and then 1 and 2 years to observe for changes. And thankfully with trials like this, we have the long-term follow-up to actually see relapse events. We're also, as another evaluation, going to be evaluating an MRI-based CNN model that I didn't discuss here that can help predict Oncotype DX recurrence score, since all these patients in this trial had Oncotype DX performed. In terms of where this is, so we actually got funding last year from a SWOG Hope Foundation Impact Award for this. What we're really waiting on now is an amendment to S1007, which should be coming in this fall to allow for this work and collection of mammograms from study sites. Basically, the plan is to start collecting mammograms for central upload, hopefully early next year, from sites that were high accruing and also try to identify sites that had high event rates, basically IDFS events. So we're hoping by next year we'll start to actually have some data from this as we collect the mammograms and apply the CNN model. And we'll be starting to identify those cases and controls with stats very soon. I think the other interesting thing about this study is actually just to see the feasibility of actually retrospectively collecting these mammograms for this type of study and in future studies. But so unfortunately, no updates in terms of results, but I think it is moving forward very soon. And hopefully once we have that plan in place, it'll go pretty quickly. So these are just the conclusions. The other thing is, like Eileen mentioned, we're now going to be hoping to incorporate evaluation of the CNN model into the design of prospective clinical trials so we can actually overcome the issue with responder, which is the retrospective collection of mammograms. So she mentioned incorporating it into her IORT trial, and then I'll talk about my concept in a second that we're hoping to incorporate into as a translational endpoint. This is just acknowledgements.
All right. Okay, thank you so much for the update. This is, very exciting. One question I have, while maybe others are thinking, did the reconsenting issue come up, or is it a consent waiver amendment to the main protocol for the
I don't think we've had that issue, right, Kathy? No, that hasn't been the issue. It's just been waiting for this amendment to go through to allow for the collection.
All right,
yeah.
it's good to know because similar. Yes, Leslie has a question.
So is there any role for this in your mammogram events trial that would include not in SWOG, but
Oh, you mean the Pembro study?
No, the gel. I think you mean the gel study.
Oh, the gel. Yeah, we could. I mean, that it's one of the maybe platforms that can be, but we are not, it's not officially, we are doing, Volpera and Cumulus and standard reading, but, to have something. Yes, we do. We have all sorts of, yeah. We could actually do that. It's a good idea because then in the literature, we would have data with different agents using the same platform. Yeah, so we have 2D, 3D, we have raw and some processed imagings, and those are all prospective, baseline, 12 months and 24 months, actually.
Yeah, I think there are probably a lot of opportunities.
Right. The primary endpoint results, that would be great. Yeah, that would be a great idea.
Yeah, I think the challenge is just finding, there are probably tons of opportunities for these, a lot of these trials have been ongoing, but just the logistics of actually getting the mammograms. We'll see how it goes with the responder too, and see how we can get the central upload for the CNN analysis.
What we had done is for the pembrolizumab, sent a questionnaire that was generated by the breast group, sent to the sites and investigators, like, do you have access and can you upload to Triad or wherever, whatever you want to use? And more than 95% had said yes. It's a newer study, but still, I mean, that way you would really know, you would have some numbers to work with.
Yeah, because I think that's really the next step, is just getting these prospectively obtained mammograms, because we have the retrospective data, but that's not what we're going to use in clinical practice.
Okay, I don't see any questions online and nothing from the floor. Since we have you up here, why don't you just continue with your concept in development, treatment tolerability with an alternate dose of exemestane or low-dose tamoxifen compared to standard dose exemestane in postmenopausal women with atypical hyperplasia, lobular carcinoma in situ, and hormone-positive DCIS.
Yeah, so this concept I've presented probably over the past couple of years, or year and a half at this point, and I wanted to highlight some of the changes compared to what I've presented before, because it's gone through some major changes just in the past few months. So as context, I took this proposal to the SWOG Young Investigator Training course just 3 weeks ago. I also took this to outside of SWOG to the AACR ASCO Vail workshop, where actually Dr. Hirschman was there. So we've been able to sort of intensively rework some aspects of this concept in the past few months, hopefully to something that is potentially more meaningful. So this is what I previously presented at our April meeting. So where this study concept started was basically drawing from the two trials. One is the low-dose tamoxifen trial that probably everyone here is aware of, comparing low-dose TAM 5 milligrams a day for 3 years to placebo in the Italian cohorts, showing a 50% risk reduction in breast cancer in this population of high-risk women with atypia, LCIS, or DCIS. And then also we're building from a pre-surgical study of alternate dosing of exemestane, looking at the standard dose of daily compared to TI week versus weekly. And the purpose of that trial was to sort of choose the winner of the two alternate doses that could be evaluated going further with a primary endpoint of change in serum estradiol, basically to evaluate efficacy. So basically our initial proposal starting from that was actually just looking at the alternate dose of exemestane compared to standard dose in a 1-to-1 randomization to 2 arms with a treatment duration of 3 years, sort of drawing from the low-dose tamoxifen. And in this original proposal, our primary endpoint was % change in serum estradiol at 1 year, sort of drawing from the pre-surgical study, as well as some data that change in serum estradiol actually correlates with breast cancer events. You know, I think the feedback that I've received since taking it to more venues outside of our group is really about the endpoint and then what arms we should be studying here. I think what we decided ultimately was that we weren't so sure that % change in serum estradiol at 1 year was a truly meaningful primary endpoint. And also I think we started to recognize that, you know, I think the big challenge in chemo prevention is not almost efficacy at this point, because that's been demonstrated in multiple places, but actually tolerability and uptake and acceptability. And so with that, this is the new proposal updated as of 3 weeks ago at the Young Investigator Training course. And so really, actually, it's a little different now. It's treatment persistence with an alternate dose of exemestane versus low-dose tamoxifen in the same patient population of postmenopausal women who are at high risk because of atypical hyperplasia, lobular carcinoma in situ, or hormone receptor positive DCIS. And so the same sort of inclusion criteria are in place, but basically the two treatment interventions are slightly different, as is the primary endpoint. So instead of comparing standard dose exemestane to alternate dose, we're now actually going to be comparing it to what we're going to call alternate dose of tamoxifen. So we're actually looking at 2 lower doses of chemo prevention. And here the primary endpoint is not a classic efficacy endpoint or surrogate. It's actually looking at persistence with initially prescribed oral endocrine therapy at 3 years. This is actually drawing from Lynn Henry and then Don Hirschman's study in young women with breast cancer looking at endocrine therapy. We sort of borrowed that primary endpoint from their study. The idea being that this might be a more objective way of really assessing if patients actually take it and continue it, because that's ultimately the goal with all these trials, is to find something that actually women will take. And so we ended up dropping the full dose exemestane, partly because, you know, I think if women are going to be interested in enrolling in this trial, they might just want a low dose option to be randomized to. So you could either get sort of the quote unquote standard low dose option now, which is the low dose TAM, which is now in the ASCO guidelines, or get the low dose of exemestane. And I think what's novel about this is we really in the chemoprevention setting have not evaluated a low dose of an aromatase inhibitor. We have the low dose TAM data, which was placebo controlled. And I don't envision that we'd be able to do a placebo-controlled trial in our patient population, especially if we were including patients with DCIS. So in terms of secondary endpoints, which I'll go into a second in other slides, we will still be looking at breast cancer incidence as an important secondary outcome and incorporating longer-term follow-up into this. It's obviously not going to be powered to compare them between the two, but at least we can observe that over time. And I think also this trial will give a rich opportunity to actually get the patient-reported outcomes that other chemoprevention trials have actually not gotten, including the low-dose TAM trial. They really looked at sort of major serious side effects, which were not different compared to placebo, and rates of hot flashes or frequency of that, but didn't do a robust PRO analysis to really look at if this was a tolerable treatment regimen for patients. And then in addition to other translational endpoints that I'm discussing more with the pathology side, one thing that we're going to do is to try to incorporate the CNN model that I just discussed as a translational endpoint to further evaluate it prospectively. So in terms of the design, so inclusion criteria and exclusion criteria are very similar to what I've presented before. So postmenopausal women who are high risk because of AH, LCIS, or DCIS. And for those with DCIS, they had to have undergone definitive breast surgery and or radiation as indicated. If they've had prior invasive breast cancer, we're excluding them because this is a low dose option and is probably not preferable in that population. They should not have received prior AI or SERM. If they had bilateral mastectomy, we'll be excluding because these are not patients we would typically give chemoprevention to. And then just related to the agents we're giving, we'll exclude patients who've had severe osteoporosis or vertebral fractures, history of clots, or history of endometrial cancer, similar to the low dose TAM study. And so the primary endpoint, which is one of the major changes, is persistence with initially prescribed oral endocrine therapy medication at 3 years. And the definition that we've pulled from the other SWOG trial is duration of time from randomization to discontinuation of the initially prescribed endocrine therapy. And discontinuation is more than 60 days without taking it or switching to a new oral endocrine therapy medication. Here are the sample size calculations. I think it's been a little challenging to sort of figure out what our alternate hypothesis is in terms of what the exemestane rate of persistence was. So we took the literature and found that in the low dose TAM arm, probably that persistence at 3 years would be about 67% based upon the data they published. And then based upon sort of extrapolating from other chemoprevention trials with full dose AIs, we'd say that maybe their persistence would be about 76%, so about 9% higher with the low dose exemestane. And with that, ultimately including loss to or like ineligibility, the total enrollment required would be 488 patients or 244 per arm. I mentioned the secondary endpoints.
We have to wrap up in a few minutes.
Okay, yeah, well, I'll be done pretty quickly. So as I mentioned, breast cancer incidence, we'd incorporate up to 10 years of study follow-up for this, do a robust PRO analysis, including those that I mentioned here, and then also get patient-reported adherence to study therapy using PMAS. As I mentioned, we would incorporate the CNN model as a translational medicine endpoint. We would not be asking patients to get additional mammograms. We would just be collecting those that would already be done as standard of care to minimize burden. Assessments should be pretty minimal to patients. We're not going to be collecting blood, which is a change from the initial study design. It would really be just every 6-month follow-up for PROs and analysis. And then I'm just bringing it back to the schema again to wrap it up.
Thank you very much. This is really indeed a lovely study. Any questions?
One thing to note too, because I'm realizing I didn't discuss this specifically. So one thing has come up with the low dose tamoxifen. So in Italy, they have 5 milligram tablets, which is the dose they studied. And sort of in practice, we either tell patients to take, because we don't have 5 milligrams in the US, we have 10 milligram doses. So in practice, we either tell patients to take one 10 milligram tablet every other day or cut it in half and take half a pill daily. I think the challenges in finding a new supplier for 5 milligrams in the US would be pretty big. And so in some sense, you could almost think of this as sort of a practical way to evaluate like tolerability to what they would take in real practice. So they could either do, I have written here as 10 milligrams tea a week, sort of same dosing schedule as the exemestane, but that's also something we're open to feedback about as we go forward with this.
I don't have a question, but I really like the new design.
Yeah, it's a big change from where we started.
All right, thank you very much. Dawn.
Yeah.
It does say a lot about how you have to think about prevention trials because, these drugs in general aren't supposed to have a lot of side effects, yet people stop them because of the side effects. And it really does go back to many of those trials looking at CTCAE for side effects for a prevention trial is wildly, misleading. So, just in terms of thinking about trials going forward and making sure that you're using the right measurements to capture information that's going to be important for patients and patient decision-making down the line is really key. So, I was really surprised when we went back and looked at how few of those trials actually had any detailed side effect information. And so, just to say going forward with the trials, they really do need to have that perspective.
All right, thank you very much.
Okay, and with that, we are exactly on time. At the beginning of our meeting, I mentioned that we had 33 people online. It was actually 57. So we had a really good attendance. Thank you to everyone who attended virtually as well as in person. I think we had a great meeting, and I hope the rest of your time here in Chicago or attending the group meeting online goes very well. Thank you to all of our investigators and of course the staff who are helping move these studies forward. Thanks, everyone.
Thank you.